So in today's session for asphyxia, we are looking at the following question. The question reads, Miss Mary Zimba, 16-year-old girl, has just given birth to a viable newborn boy. The APGAR score is 3 out of 10 with a birth weight of 1.8 kg. On assessment, there is aspiration of meconium and the diagnosis of asphyxia is made. Question A says define asphyxia, neonatal. Question B, state 5 predisposing factors of asphyxia, neonatal. Then question C, identify 5 problems that baby Zimba may present with and use the nursing care plan to manage him. Question D, outline 5 points you would include in your information, education, and communication to Miss Zimba before discharge. So we'll go straight to look at the question. In terms of defining asphyxia neonatorum, we can define it as this is a neonatal emergence condition in which there is failure of the baby to initiate and sustain breathing at birth, characterized by difficulties in breathing and cyanosis. So when we talk about asphyxia, asphyxia simply means that this baby has failed to breathe at birth. Now, when the baby is in the mother's womb, the baby does not use the lungs to oxygenate the blood. This is because there's what is known as the fetal circulation, where the baby benefits from nutrients, oxygen, and removes waste product through the mother's blood because the lungs are non-functional. The lungs only become functional immediately the baby takes the first breath. Now, there are certain circumstances or problems that may hinder this baby from taking the first breath as they are born. Or sometimes it could be the baby fails to sustain these breaths. Maybe the baby takes the first deep breath, but the baby fails to continue breathing based on what the problem is. And then we'll know to say this baby has suffered from what is known as asphyxia neonatal. In terms of the characteristic that we see, one of the characteristics is of course difficulties to breathe, and we'll also see cyanosis. The baby will begin to turn bluish instead of pinkish color, and then we know to say this baby may be going into asphyxia. The question says state 5 predisposing factors of asphyxia neonatal. So the way this question is, you can pick any of the 5 symptoms, but you state them, meaning that you put a reason there. You don't just list them, but you add a reason at the end. Now, I have grouped them because sometimes you may see questions which will say state 5 characteristics of, predisposing factors of asphyxia according to groups, meaning that you need to group them the way the presentation is. But for the way this scenario is, you can pick any 5 from the following groups of symptoms that we are going to talk about. And the first group of symptoms are fetal causes, in terms of fetal causes of asphyxia. Amongst the fetal causes, we have prematurity itself. Prematurity, this is because of immature lungs, which may not maybe have adequate surfactant to promote breathing. Hence, prematurity may easily lead to asphyxia. Apart from that, fetal infections, where the baby is born with infections like toxoplasmosis, rubella, cytomegalovirus infection, herpes simplex virus, all these infections may affect the baby's ability to breathe, resulting in asphyxia. Also, congenital anomalies such as those of the heart and the lungs, where maybe the baby is born with incomplete formed lungs. All these may lead to asphyxia, or even defects of the heart. Remember, the baby has shunts when the baby is in the mother's womb, whether blood is able to move between one atria to the other atria without being recirculated through the lungs, because the lungs are not functional. So those shunts are supposed to close when the baby is born, so that blood flows through the lungs and comes back through the other side of the heart. But if these do not close, they will make the baby have more carbon dioxide rather than oxygen, making the baby to go into asphyxia. Also, other fetal causes includes fetal anemia, because in fetal anemia there is reduced oxygen carrying capacity of the blood. Intrauterine fetal retardation or growth restriction. This is often due to chronic hypoxia in utero because of underdeveloped body organs. So in terms of some of the fetal causes, these are the causes that we can see. We also have maternal causes of asphyxia. The first one is preeclampsia, including eclampsia itself. And these two, they will lead to poor placenta perfusion. And because the baby is not receiving enough oxygen, the mother's body will decide to eject the fetus too early. And also, maybe this may also happen at the time of birth, where the mother goes into eclampsia. It means that the baby stopped receiving oxygen for some time. And when the baby is born flat and not breathing, because they were lacking oxygen for some time when the mother went into eclampsia. Diabetes mellitus, this is because of increased viscosity of blood, and this reduces oxygen supply to the fetus, which will cause fetal distress and also congenital problems. Severe anemia, this lowers oxygen transportation to the placenta. Infections such as chorioamnionitis, HIV, malaria, among others, all these, they reduce oxygen carrying capacity to the fetus itself. Maternal hypotension or shock, this reduces uteroplacenta blood flow. So the placenta will be receiving less blood, meaning that the fetus also receives less blood, and the fetus may be born flat or not breathing. We also have placenta causes. One of the placenta causes is what is known as placenta previa. Previa means before. So when we talk of placenta previa, we always bring in the aspect of the implantation, how the implantation occurs in the uterus. So meaning that you need to have the picture of the uterus in your head. So this is just the partial drawing of the uterus, and of course we have the eggs there. So when we say previa means before the cervix. So if this is the cervix, of course, and then we say the patient has placenta previa, it means that the maternal site of the placenta is closer to the cervix, or even partially closing the entire cervix. So we'll have this as our baby, and we have this as the membrane. But remember, the placenta has the maternal site and the fetal site. So the maternal site is this meat part that attaches to the walls of the uterus. So now, if this particular part is closer to the cervix, tearing can easily occur to this point, causing the mother to bleed before they deliver. Now, with placenta previa, when the placenta remember, placenta previa has grades. There is 1 up to 4. And from 1 to 3, the placenta maternal site, which is this part, is not completely closing the cervix, but it is closer to the cervix. So these cases of placenta previa, you see the mother bleeding when they are even maybe at term, and when they have even gone into labor. but because the cervix has to open to around 10 centimeters, this opening will cause now tearing of the maternal side, causing the mother to bleed before the baby is out, meaning that the baby would have been deprived of oxygen for some time. Then we have, when we talk of grade 4 placenta previa, where the entire maternal site of the placenta is covering the cervix, this tearing and bleeding may even occur before the mother reaches term, or before the mother reaches 9 months, because the stretching effect of the uterus as the baby grows may cause tearing and rupture of the blood vessels on the maternal site, making the mother to bleed way before going into term, and this may cause the baby to be deprived of oxygen, causing the baby to go into asphyxia at whatever point you deliver the baby. So when we talk about placenta previa, that is what happens for it to cause asphyxia. It is because of course the abnormalities causes bleeding and poor oxygen exchange before the baby is born. Then when we talk of placenta abruptio, placenta abruptio means that the placenta has detached from the walls of the uterus before the baby is out. The normal process is that the baby should be delivered, then within 15 to 30 minutes, the placenta should now detach and be delivered, because the placenta is the point through which blood, oxygen, and nutrients were being exchanged from the mother to the fetus. But in abruptio, the opposite occurs. The placenta detaches before the baby is out, meaning that the baby can't breathe because the baby is not yet born. So at this particular point with placenta abruptio, the baby goes into asphyxia because of prolonged lack of oxygen. Also, placenta insufficiency, where the placenta probably didn't develop enough. In this one, this is because of long-term lack of oxygen and nutrients due to damage of an aged placenta. Calcification or infections, this reduces placenta surface area for gaseous exchange. So calcifications, you find that in certain, especially when you have a child in old age, maybe above 35 or 40 years, you find that calcifications easily occur, and then it means that exchange of blood and oxygen will be reduced in this particular baby. Hence, the chances of complications like asphyxia increases with old age. So this is placenta previa that I was talking about, meaning that the placenta, the normal is that the placenta should be at least implanted on the fundal height of the uterus. But placenta previa, we have the marginal one, meaning that it is closer to the cervix but not on the cervix. Then we have the partial one, where the placenta maternal site is almost on the cervix, part of it is on the cervix. Then we have the total one, where the entire maternal site is on the cervix, and this area has to stretch when labor starts. Even just for as the baby is growing, this area will also be stretching, and these blood vessels will easily break, and this woman starts bleeding or spotting way earlier before going into labor, and this will deprive the baby from enough blood and oxygen. Okay, other causes, we also have what is known as umbilical cord prolapse, where the cord slips ahead of the baby during labor and gets compressed. This will deprive the baby from enough oxygen. A narco cord, this is where the cord is wrapped around the baby's neck, reducing blood flow. Remember, during mechanism of labor, during second stage of labor, when the baby's head is out, you need to go through the neck to feel for the umbilical cord. If there's no umbilical cord, you wait for restitution to take place. But if there's an umbilical cord, you need to do maneuvers to make sure that the cord is not clamped, because the baby will be deprived of oxygen. True knots, these true knots may tighten during labor and limit circulation. True knots is where the knot makes a complete figure, Maybe because of the baby swimming, the knot makes a complete figure like that, and it will somehow, as it begins, it will somehow look like an 8. It will somehow look like an 8 with a string attached to the baby like that. But then as the baby descends, remember this part is attached, is coming from the uterus. So as the baby descends, this knot will become a complete knot, like a shoelace, the way it is, because the baby is descending, the baby is trying to come out, and that is going to tighten the umbilical cord, cutting circulation completely between the mother and the fetus, and this is what may result in asphyxia. Cord compression as well, maybe from oligohydramnios or entanglement. Oligohydramnios, where the baby has more amniotic fluid than the baby's size itself. So this will give a bigger room for the baby to be swimming through, and this may easily cause entanglement of the umbilical cord, causing asphyxia. The last group of causes is what is known as drug causes, such as magnesium sulfate, the drug we use in preeclampsia to prevent seizures, may cause respiratory depression in the mother, and this may affect circulation of oxygen to the fetus. That is why we calculate MAGSAF specifically, and we make sure that as we give those 14 grams, we are giving them specifically in a particular order to avoid overdose, so that the mother doesn't go into respiratory depression. Narcotic drugs or opioids like morphine, pethidine, during labor, these can also cause respiratory depression in a newborn. Anesthetic drugs, general anesthesia, may cross the placenta and affect the baby. Also, other illicit drugs like cocaine, heroin, these can cause fetal distress and asphyxia as well. So also these drugs may result into asphyxia. So when the question says mention 5 causes, state 5 causes, you can pick any 5 from all these 5 groups we have talked about. But when a question says according to groups, mention 5 causes of asphyxia, you need to group them the way I've grouped them, then you mention the 5. Then the question C said identify 5 problems that baby Zimba may present with, and using a nursing care plan, explain how you will manage them. The first problem that we can see is ineffective breathing pattern, and the nursing diagnosis, you say ineffective breathing pattern related to immature lungs evidenced by cyanosis. The goal, you can say the patient or baby will have normal breathing pattern within 30 minutes of nursing intervention. If you are using objectives, you can say to improve the breathing pattern within 30 minutes of nursing interventions. The interventions, all you need is just 4. And in terms of the objectives, you can say, in terms of the interventions, rather, you can say the first one, you can say I will place the baby in the lateral position to aid drainage of secretion and prevent aspiration. The other point, you can say I will clear the airway using penguin sucker to promote a patent airway. I will administer oxygen at a rate of 1 liter per minute to improve tissue oxygenation till respirations are well established and skin color is satisfactory. I will avoid placing food in the mouth of the baby to prevent vomiting and choking, which may worsen respiratory distress. So avoid placing food, specifically avoid breastfeeding the baby before you relieve the difficulties in breathing. Evaluation, you can say the baby's breathing pattern improved within 30 minutes of nursing interventions, evidenced by absence of cyanosis. So the way the marks allocation is that for a correct problem, you get 1 mark. Correct nursing diagnosis, which is supposed to be related to something with an evidence, if it is an actual problem, you are given 2 marks. But if it is a potential problem, there is no evidence, and you see as we talk about potential problems as well. Correct objective or goal, you get 1 mark. For 4 interventions, you get 4 marks. For correct evaluation, and an evaluation should always have an evidence, you are given 2 marks. So this is how come you get 10 marks for 1 problem, and for 5 problems you get the 50 marks that is allocated in the question. So the other actual problem that we can see in asphyxia in terms of nursing care plan is altered thermoregulation. And altered thermoregulation is related to underdeveloped heat regulatory centers and inadequate adipose tissue, evidenced by low body temperature of 35.5 degrees Celsius. For go, you can say baby will be relieved of hypothermia within 1 hour of nursing interventions. Interventions: I will nurse the baby in an incubator to keep the baby warm. I will cover the baby with adequate linen or layette to provide warmth. I will switch on the heater to increase and maintain the room temperature between 20 to 24 degrees Celsius for adequate warmth. I will immediately change soiled linen and wet linen and bare clothes to prevent chilling of the baby. Evaluation: baby was relieved from hypothermia within 1 hour of nursing intervention, evidenced by temperature of 36.5 degrees Celsius. Other problems are potential problems like this one: risk for imbalanced nutrition less than the body requirement. The nursing diagnosis, you say risk for imbalanced nutrition less than the body requirement related to poor sucking and swallowing reflex. The goal, you will say the patient or baby will have adequate nutritional status throughout hospitalization. Interventions, you can say I'll assess the baby's ability to suck and determine appropriate feeding method. The other intervention: if the baby is unable to suck and swallow, I will pass a nasogastric tube to provide an alternative way of feeding. I will do daily blood sugar tests or checking to monitor and prevent hypoglycemia. The last intervention, you can say I'll give expressed breast milk by nasogastric tube to meet the baby's nutritional demands and prevent malnutrition. For evaluation, you say the baby's nutritional status was promoted throughout hospitalization, evidenced by weight gain. So for evaluation, whether your problem is a risk or your problem is an actual problem, the evaluation should always have an evidence to get the 2 marks. The other potential problem is risk for infection. Nursing diagnosis: risk for infection related to immature immune system. Go, you will say baby will be prevented from infections throughout hospitalization. Then in terms of intervention, you say I'll wash hands before and after attending to the baby to prevent infections. I will not allow people or staff with respiratory infections to enter the nursery to prevent transmission of respiratory tract infections to the baby. I will regularly clean the incubator to remove dirt which harbors pathogen microbes. You can also say I'll administer prescribed antibiotics to prevent infections from being established in cases of contamination and successful entry of microorganisms in the baby's body. Evaluation, you can say baby has been prevented from infection throughout hospitalization, evidenced by the temperature of 36.5 degrees Celsius. The last problem is risk for fluid volume deficit. So risk for fluid volume deficit related to poor sucking and swallowing reflex. Go, you say baby will have adequate fluid volume throughout hospitalization. Intervention: if the baby is unable to suck and swallow, I will pass a nasogastric tube and give expressed breast milk by nasogastric to promote fluid volume. The other intervention, I will encourage the mother to breastfeed the baby to prevent fluid volume deficit. I will give normal saline 5 ml per kg body weight to promote fluid volume. I will give dextrose 5 ml per kg body weight to promote fluid volume. So those are the interventions that you can put. Evaluation, you say baby's fluid volume promoted throughout hospitalization, evidenced by absence of poor skin turgor or presence of moist skin. So in terms of nursing care plan, these are the problems that you can use. And these problems and this nursing care plan specifically, the way it is and the problems, you can use them in conditions like prematurity. You can also use them in conditions like respiratory distress syndrome. So these problems apply in all the three pediatric emergencies. Also, the nursing management that we did in RDS applies also in the three conditions, the same the way they are. So it becomes easy as you study that you have at least the managements that apply that are the same in these three conditions. The last question said, you explain 5 points you can give to Miss Zimba before discharge. One of the IEC points you can give to the mother is nutrition. You advise her the importance of breastfeeding the baby every 2 to 3 hours to support growth and immunity. You can give advice to the mother on prevention of hypothermia, where you teach the mother on skin to skin care, which is also known as kangaroo care, and the importance of keeping the baby warm. You teach the mother on infection prevention, hygiene practices like hand washing before handling the baby, cord care. You advise her not to apply any not to apply any herbs like cow dung on the cord and any other herb to prevent infections. Teaching danger signs to the mother child, such as poor feeding, difficulties in breathing, fever, lethargy, and you advise the mother to immediately seek medical help. Importance of immunization, where you explain the schedule and importance of completing the immunization schedule so that we prevent vaccine preventable diseases. Importance of hygiene, importance of baby bath, cord care by use of pre-boiled cooled water, and no herbs on the umbilical cord. All these also can fall under hygiene points. So in terms of IEC to the mother, you write headings like that and give explanation. You can even expand these guiding points that are on this particular heading. Then the other aspect that we have not talked about that is still in the question is the issue of classification, because asphyxia can also be classified. And in terms of classification, we have what is called as the normal, where in terms of the normal, you look at the color. Remember, we are talking of the APGAR score. APGAR score, you are talking of the appearance, the pulse, the grimace, you're talking of the activeness, and also the respiration. So in terms of the color, normal, the baby should be pink. The muscle tone, the baby should have active movements. Heart rate at least above 100 beats per minute. Respiration, at least they should be regular, and the baby should have a strong cry. Reflexes should be normal. At least the baby should have good response to stimuli, and the APGAR score should be between 7 to 10 at 1 minute. And sometimes, in some cases or some other hospitals will say 8 to 10, but 7 to 10 will still be considered normal at 1 minute, and this should improve after 5 minutes. The next classification is what is known as mild asphyxia. In terms of mild asphyxia, for you to tell that the baby has mild asphyxia, the color, the child looks slightly pale or bluish. Apart from that, muscle tone, there is some decreased muscle tone, of course. Then apart from that, the heart rate is greater than 100 breaths per minute. Respirations, the baby has irregular or a weak cry. Reflexes, there is a decreased response. Up-gas score is between 4 to 6 at 1 minute. Then in terms of management, the baby may need minimal resuscitation and stimulation or oxygen supplements as well. Then the other classification is severe asphyxia. Severe asphyxia, in terms of the color, the baby looks pale or blue. Muscle tone, the baby limps or floppy. There is poor or no response at all. Heart rate, it is less than 100 beats per minute or even absent. Respirations, the baby may be gasping or there may be no respirations whatsoever. Reflexes, they are very poor or absent. Up-gas score is between 0 to 3 at 1 minute. And in terms of the general management, the baby needs immediate or advanced resuscitation, where maybe you use even a positive pressure ventilation, chest compression, or even medication just to kickstart the baby's ability to breathe. So these are other aspects that are not there in this question that you need to read through and understand. And of course, just also read through the signs and the symptoms, because they were not part of this particular question. So in terms of this question for asphyxia, that is how you can attempt it. But other aspects, you may still be asked maybe to use the management. The question may say using the nursing management, describe the management of the baby, meaning that you use the nursing management that we have talked about in RDS, or the nursing management that we have talked about in prematurity, because it's the same. So also in those other questions that we'll look at in prematurity and RDS, if you're asked for nursing care plan, you're using this same nursing care plan that we talked about in this question, because you use them interchangeably. So that is about how to manage asphyxia. Till next time, goodbye.